Welcome to the AUA News Inside Tract podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Well, hello, Dr. Santiago-Lastra. It's a pleasure to be in your presence as always.
Same here, same here.
We need to talk vaginal estrogen, vaginal hormones, and genitourinary syndrome of menopause, which I for one have been thrilled to see the AUA, the American Urological Association, and urologists really take the helm with these guidelines that came out last year.
Absolutely. I think the guidelines really set out a path to success. And first and foremost, thank you to the AUA for getting us together today for this AUA News Inside Tract podcast. Many of you may know my esteemed colleague, Dr. Fenwa Milhouse. I am Dr. Yahir Santiago-Lastra. I'm a urologist at UC San Diego Health. And even though she needs no introduction, I will let my colleague, Dr. Milhouse, tell you a little bit about herself before we get started.
I am Dr. Fenwa Milhouse. I'm a board-certified urologist and fellowship-trained female pelvic medicine, reconstructive surgeon, urogynecologist, ERPS, like my colleague, Dr. Santiago-Lastra. I am in Chicago, and I own my own practice there called Down There Urology. I'm also very, very visible on social media, nicknamed your favorite urologist. And it is a pleasure to talk about this, and I thank the AUA as well for allowing us this moment to share with you.
Absolutely. And May is Women's Health Month. So we wanted to dedicate time to a topic that impacts millions of patients, but is often, even with all of the recent developments, frequently underdiagnosed, undertreated, and that is genitourinary syndrome of menopause.
Absolutely. Both of us, I believe, have been practicing around the same amount of time, around a decade. And I know you probably feel the same way. I've seen what feels like millions of my patients, millions of women suffer from a lack of understanding among the medical community, urologists, primary doctors, gynecologists included, around GSM, genitourinary syndrome of menopause, and the safety regarding vaginal estrogen. I am hopeful, though, because looking at things 10 years ago when we first started practicing, and now they're different, they're better. Patients are more informed, they're less hesitant. I feel like I'm seeing more other of our colleagues starting to catch the memo as well. How do you feel?
Absolutely. I think the narrative has changed significantly along GSM. And in particular, even the name, the moniker genitourinary syndrome of menopause, or GSM, is the modern term for what used to be called vaginal atrophy. And it describes this collection of urinary, vaginal, sexual symptoms that essentially happen when estrogen levels drop during and after menopause, and what comes of that, particularly in the pelvic floor. So I think it's incredible that we've made it this far, that we have a term for this, and more importantly, we have a guideline. And now we understand why urologists should recognize this. Even with all of these advancements, Dr. Milhouse, why do you think it's still so underdiagnosed and undertreated?
Well, I think medicine is slow. The change is slow in medicine. We aren't good at examining the vulva. Okay. We skip right past it to examine the cervix if you're a gynecologist, or do a pelvic exam. We in urology may skip past it as well, or not do it at all. A lot of these symptoms get lumped into bladder UTI bucket, and get treated with antibiotics versus thinking of it from a genital urinary at GSM hormonal standpoint. And then most importantly, I think it's this fear around estrogen. It's a fear that we have that has been passed down for a generation of us physicians around prescribing estrogen. And so shedding that fear is going to take maybe another generation before, it truly is shed. I have spoken to some of our colleagues and asked them, like, why aren't you prescribing vaginal estradiol? I, and a few of them have said, I just don't want to get into the hormones. I don't want to, and I'm like, why? What's you're nervous about? I think it's a lack of education. There's a lot of misconceptions around vaginal hormones and their safety and how they're different from systemic hormones. And I think that is what you and I and a lot of our other colleagues are trying to do and get the message out.
Absolutely. And for those of you in the audience who are listening, there may even be some patients in the audience. This fear that lingers stems from the Women's Health Initiative, or WHI study, that was done in the early 2000s. And this study made both patients and their doctors very wary of any estrogen containing treatment, even safe low dose vaginal estrogen. So even when we know that all forms of estrogen supplementation can be done safely if you follow certain guidances, the absolute safest topical treatment is vaginal estrogen. The formulations for vaginal estrogen and the dosing are so low that they have done many studies to show how much of that estrogen actually makes it into the bloodstream, and the concentrations there are not significant enough to be clinically impactful. So that's really important for the patients to know. But the resulting aftermath of that study and this fear, is that roughly half or more of all postmenopausal women will often have symptoms that go unaddressed because we're either not asking, as Dr. Milhouse is saying, or maybe we're worried about it, but we're afraid to treat because we're afraid of estrogen. And that's, these are symptoms that you might even see every day. So Dr. Milhouse, what messaging do you think physicians need to hear, or how do you help people feel more comfortable with this when you have these conversations?
I think number one, getting people to be comfortable recognizing genitourinary syndrome and recognizing that it's a clinical diagnosis. You don't need a single blood test to prove somebody has GSM. Okay. So you don't have to do a fancy workup at all. Just putting the clinical clues together. You have a patient that's perimenopause, menopause, or postmenopause or beyond, with bothersome urinary complaints like urgency, um, urinary pain, urethral pain, bladder symptoms. You have a patient with vaginal dryness, vaginal pain, either alone, vulvodynia, or with penetration, dyspareunia, patient with vaginal itching, vaginal irritation. Oftentimes patients will be like, it just is irritated down there. It burns down there. And people always assume that burning is automatically dysuria. It's pain with urination, it's UTIs, but you got to listen. I always ask the patient, when is it burning? And if they're saying it just burns, like it's burning now, it burns when I sit down, it burns whether I'm peeing or not. Think about that, okay? Think about that differently. Recognizing that these symptoms are likely GSM, recognizing how common GSM is. You said 50% or more of individuals, women, are vulva owners are affected by this. So more than half are affected, extremely common. And then the messaging is crystal clear. And I say this, I haven't met a vulva vagina that couldn't get vaginal estrogen. Okay. Okay. I have not met a vagina that could not get vaginal estrogen. They can get it if they're old. They can get it if they're young. They can get it if they're lactating, breastfeeding. They can get it if they're smokers. They can get it if they've had blood clots. They can get it if they have had breast cancer themselves. Okay. You don't need to check labs. You don't need to worry about giving them progesterone. Um, we do recommend consulting with their oncologist if they are a breast cancer survivor, as a courtesy, um, more than anything. But it makes it simple for any one of us to start really helping these people.
I love that. It almost sounds like a nursery rhyme. As Dr. Seuss, anyone can get it. Yes, you can. Anyone can
Yes.
get it. Vaginal estrogen.
Yes. Yes.
Absolutely. One really important thing that Dr. Milhouse just mentioned is that it's very, very easy to prescribe. And you can prescribe low dose vaginal estrogen in a postmenopausal woman, even if you haven't yet done a physical exam. So these types of complaints, the recurrent UTI, the dysuria, the overactive bladder symptoms, the dryness, all of these symptoms may come up, for example, during a telehealth visit. And that is an easy intervention that you can do even before you've done the pelvic examination. So, even that part you can prescribe based on symptoms alone. And what's really important for people to know. So
Thank you for saying that. I
that's
agree.
gonna make access so much better. Another, I have some questions for Dr. Milhouse on making it practical and solvable for any type of patient. One question I had before we go into the practicalities of prescribing this medication is, how do you think the removal of the boxed warning is going to impact the accessibility of it? Because this has just happened. What types of barriers do you think that eliminated?
Okay, so we talked about the barrier of just even a patient getting diagnosed and getting the prescription, right? The physician recognizing and then writing it. Then there's the barrier of the patient actually taking it. Okay, that is a real barrier. And I would say up until probably the last maybe year or two, this is a barrier that I had a whole spiel for patients, because patients are also, like you said, have been made to fear estrogen, right? So you tell them, I'm going to prescribe this vaginal estrogen, and they're already have their guard up. Okay.
Yeah.
Then they go pick it up, and they would get the insert, and they get this black box warning. And they would say, "Oh my God, my physician is prescribing this medication that could cause me cancer, that could cause dementia, that could cause heart problems. I'm not taking this." And you see them back in follow-up, and they're no better because, "Oh yeah, I never took that thing. I read the side effects, and I didn't want anything to do with it." This is so common, especially because a lot of us don't have the time to to speak to the patients like we want to, and so we just write a prescription, hope for the best, and they have not taken it. This has happened
true.
so often, so often. So I used to already prep my patients like, "Okay, I'm going to prescribe this. It's safe, 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 safe. By the way, when you pick it up, when you get the insert, if you read it, it's going to make me sound like a liar. But I promise you that we have data that makes that this is wrong." And I used to tell patients, like, we're actively fighting the FDA to change this. I would tell them, like, this is something we're actually trying to get changed. It's so great to have said that all these years. And then last year have that come to fruition, where the FDA recognized that this label is super outdated. It just slapped it on all forms of estrogen, didn't discern the difference. And it is extreme barrier to patients getting the help that they need. So removing it has been monumental. Monumental. Okay, because now the patient doesn't get that black box warning when they pick up their vaginal estrogen. Okay. The patients, I don't have to give that big of a spiel anymore these days. I've already seen the benefits, because my spiel has turned from this like 5-10 minute thing to like a 1 minute thing, if that. Patients, as we know, are coming in more informed anyway. It's now more times than not, their friends, their somebody on social media they're following has already told them about vaginal estrogen. You know what I'm saying? I had a daughter bring her mother in, and she already knew what she was like. My mom's got a couple UTIs. I want a vaginal estrogen ring. And so that never used to happen before. So
Yeah.
it's a lot easier for our colleagues to prescribe now because the patients are more informed. They're less fearful. We don't have that black box warning. Thank you, FDA.
Yes, absolutely. So we see a lot of these downstream barriers. We are trying to eliminate the prescribing barrier, the access barrier by improving education. The black box warning eliminates that last bit of hesitancy on the part of the physician or the patient to trying this medication out of just fear and fear of risk of harm. So that's been eliminated, which is a really great coup. And then we come to the actual medication itself and the practicalities of what to prescribe. So there's tablets, there's suppositories, there's a compounded form, there's the rings. Uh, what Give us a
There's an
little
oral
cheat
pill.
sheet. There's a
There's an
pill, ospemifene. Yes, a selective estrogen receptor modulator. That's really important for people to know. And then there are also other hormones like DHEA or progesterone that have very promising data, although estrogen is much better studied, that they can also help very significantly with these types of symptoms. So take us through how you prescribe these, like what guides your decision making. Give us an easy way of how you think about each of these medications and how you choose them for particular patients.
The best treatment is the treatment that the patient will do. Okay. The best treatment is the one the patient will actually do and stay consistent with. So at the end of the day, all of these options, with the patients telling me the only thing that I want to do is XYZ, this type, and that's the only one I'm willing to do, here you go. Okay. Because that's the best treatment is the one the patient does. All right. And also we know that cost is a barrier, right? It's expensive out here. So you have to think about the cost for your patients, for a majority of them. So I simplify things for the vast majority of people because it can get very overwhelming. By far the most accessible options are either vaginal estradiol cream. That is number one, the most accessible option, the cheapest option. If you don't have insurance, you can get a tube of vaginal estradiol cream for like $15 uninsured. Okay. So that is accessible and relatively, and that tube may last that patient a couple months. So that is my number one go-to. All right. And by the way, that $15 price, you can get that through Cost Plus Drugs. Yes, it is back in stock. Okay. Get that through Cost Plus Drugs. They don't need insurance. It's like $13 and then maybe $5 for shipping. Okay. So that is my number one. Obviously, you can send it to their local pharmacy, and the pricing again for it is usually pretty good for most. Remember, Cost Plus Drugs. The other one that is relatively accessible is the estradiol insert, the tablet. Okay. Or it's called an insert. Some people call it a tablet. A few of my patients call it a pellet, which is really confusing. It's not a pellet the way we think about it, but it's basically just this inserted tablet that dissolves overnight. Very simple dosing, super simple dosing. And that I generally utilize for patients who want no fuss with the cream. They're like cream averse. They just, I don't want to fuss with any creams. I tried it, Dr. Milhouse. I just don't like it. And okay, here you go. Just do this to tablet because it's no mess, no fuss. It's not my go-to for everybody because I am partial to the topical placement of a cream on the vulva. So the ability for a patient to put the cream on their vulva, the tablet, they can't directly do that. That is why I prefer cream to any tablet version, but that is a legitimate version. Okay. Then there is, I'm going to get to DHA in a moment. Then there is, what about the patient who cannot access their own vagina or vulva easily? The grandma, little old lady who's in a nursing home or who just has mobility issues. They can't reliably do that, right? They have recurring UTIs, they have whatever, and you need to get estrogen to the vagina. You have two options you can help these women. You have two options. One is you have the S string, okay? The S string, and it is a ring, very flexible, small, smallish ring that is placed in the vagina in the office. It can be placed in the office by you or a physician assistant every 3 months, and it gives low dose vaginal estrogen. It's one dosing. If you pull up S string on your EHR, it's one dose. Okay. Every 3 months, patient comes in with their S string. You take the old one out, put the new one in. They're getting low dose vaginal estrogen, no fuss. The second option for those same patients who can't access their vagina or don't want to access their vagina for whatever reason is Osphena, Osphena, ospemifene, which is the only oral option that is for the vagina. I know it's crazy. It's an oral pill, but it only works for the vagina. It's FDA approved for GSM. Okay. And it's a selective estrogen receptor modulator, or SERM. So it upregulates estrogen in the vulva and the vagina specifically. And that's how it works. And that is one dosing. I think it's 60 milligrams, one dosing. That's it. One tablet that they take daily. It's and that has been shown to help. Okay, it's a legitimate option. So I want my colleagues to remember these two options, because there will be those exceptions of people who just cannot do any kind of vaginal route. Obviously, you mentioned DHEA. DHEA is a precursor hormone for estradiols and testosterones. DHEA in a perfect world would honestly probably be the preferred option, because the more we know, the more we're finding out, the more that we realize that testosterone is really important for the vulva, really important for the vulva. And an ideal option actually delivers both. That's probably another podcast for another time.
But absolutely, I was going to say.
we don't want to overwhelm people. But DHEA is the only FDA approved, commercially available option that allows an individual to get the advantage of both the estradiols and the testosterones. It's a suppository, goes by the name Intrarosa, or Prasterone is the generic. Intrarosa, it's a suppository. So where the vaginal estradiols, the inserts creams, are like 2 or 3 times a week, typical dosing, this one is daily.
Correct.
Intrarosa is every day the person, it's dosed daily forever. It's a suppository, a little bit different than the inserts. The suppository is like a waxy, thicker suppository. Thinking of a word.
It's the vegetable oil.
Yes. Put inside the vagina, dissolves overnight. And that is a legitimate option too. One that some patients will ask her by name and prefer. And it's important that our colleagues know how to prescribe that. Again, it's one dosing, it's daily, and it's a little bit more expensive than the estradiols, but I have found that it is the best pricing I've gotten is around $80-$90 per month.
The one thing about Prasterone or Intrarosa, also for our Inside Tract listeners, it's the one FDA approved treatment for female sexual pain or dyspareunia. So if you have a patient with these types of symptoms who's primarily presenting with dyspareunia, this is FDA approved for that indication. What I found, I take care of a very underserved patient population. Those of you who know me know that there can be some inherent struggles with that as well. I've found that the only way to have Intrarosa approved, if I'm using it to treat GSM symptoms and not dyspareunia in particular, is to also include the diagnosis of dyspareunia, so that it becomes a covered benefit. If I try to prescribe it using GSM or vaginal atrophy as a diagnosis codes, I may actually get a denial. So that's something to know, especially in this climate where the diagnosis codes that we use for a lot of the conditions that we treat are going to be looked at with a fine tooth comb. to make sure that our diagnoses are accurate. So just something to keep in mind. FDA approved for dyspareunia. Make sure that you include that if you are thinking of prescribing it, particularly for your patients who are on Medicare or who have some of the lower cost insurance plans, so that you do not get an inadvertent denial.
That's huge.
Yes.
Thank you for taking that. I want to say something else about DHEA. Is it might be the one option that the breast oncologists are okay with when they're not okay, if they're not okay with actual estradiol. So if you have a breast cancer patient, you've reached out to the oncologist and they're like, yeah, I prefer we avoid that, but then bring up DHEA. Okay. Bring up intrarosa. Because it appears to, I mean, all of it is safe, to truth be told, but it appears to be the one option where you'll get probably more oncologists on board, particularly if they're on
Absolutely.
If they're on certain medications, a post, for their breast cancer treatment.
Absolutely. And I find it really rewarding to loop in the oncology teams typically. And most patients will be more than happy to facilitate that communication with their oncologist. It's a really easy thing to do. And there are even still some older school oncologists there who still don't feel as comfortable with the estrogen bandwagon as many of us are. So it's always great to bring them into the conversation. So we've talked about a lot of things that I did want to recap for our listeners. Firstly, add those screening questions that Dr. Milhouse mentioned for all of those postmenopausal women. Just asking, do you experience pain with intercourse? Do you have that burning? When do you have burning? Is it with urination? Is it all of the time? Do you experience dryness? Those are great screening questions for genitourinary syndrome of menopause and can easily facilitate a prescription for vaginal estrogen, even in the absence of a pelvic exam. So it's very easy to do this during a telehealth visit. Think of GSM, another pearl that she mentioned. Think of GSM when you're treating overactive bladder or you're treating recurrent UTIs. Think of estrogen as a foundational treatment before you start talking about Botox injections, sacral nerve, putting patients on antibiotic prophylaxis. The estrogen is not the be all end all cure, but it's a great foundation. It's like prescribing, serum for your facial wrinkles without wearing sunblock. It's one of those foundational treatments that you need. So remember that pearl as well. Normalize the
I love that
conversation.
analogy.
Normalize the conversation. Have it with your colleagues, with your oncology team, and then keep treatment options on hand, like Dr. Milhouse mentioned. Being ready to prescribe or recommend it to patients, having handouts available, that can really streamline the entire process.
That was a perfect recap. I love that you brought in the piece about the foundation of estrogen, even for us in ERPs or that treat overactive bladder, right? When we were learning in fellowship, we didn't learn necessarily that vaginal estrogen could help overactive bladder. And I remember first learning that and being like, no, that can't, I don't know about that. That seems like a stretch. And then seeing patients give them vaginal estrogen, they're like, oh yeah, my overactive bladder is better too. And I'm like, wow. So now it's part of that foundational thing. I see somebody with overactive bladder. Oh, by the way, you know what? We're going to do vaginal estradiol on top of the behavioral changes and the me talking about medications and potentially procedures. Yeah, I love that.
I love that. And one other pearl that I think is really important is that another barrier that can come up is patients will start the medication. Particularly, I find this happens with the cream. And then they'll say, oh, I have to stop this because I started experiencing more itching and more discharge, or I got bacterial vaginosis. And sometimes patients will have something called dysbiosis, which means that their flora, their vaginal flora, all out of whack. Remember, antibiotics, when you take them, will destroy all the flora. And so as you rebuild, that is definitely something that can happen while on vaginal estrogen. It's really important to coach patients through that period in time, treat that if necessary, switch from a cream to a suppository if necessary, but not discontinue, because eventually that is a non-issue. When you start it, these types of things can happen. And the reason is because estrogen is also a foundational treatment for your normal flora. And the mechanism is that estrogen stimulates those vaginal cells to produce lubrication. That lubrication is extremely rich in glycogen, which is the number one nutrient for bacteria in the vaginal area, lactobacilli, and a bunch of the others. It may also lead to an overgrowth of the bacteria in the vagina that you may not want, but that is a temporary thing that can happen sometimes, easily treatable, and then you can continue with treatment thereafter. I am always disappointed to see patients who are like, oh, I tried vaginal estrogen and then I started to get discharge and itching and other things, and so I just don't want to use it. I try to encourage them to try other options. Dr. Milhouse gave you a bunch of alternatives. Really important to coach people through that time, because it may be something that surfaces, especially in the beginning. Some of these formulations can cause a little more irritation, a little more itching, and that may also lead to some changes in prescriptions, but don't give up the treatment for those side effects, because they're easily workable. You can work around them. And the benefits of these medications are often not to be felt after about 6 months of treatment. So that's another thing, to invest the time and the energy to use these medications, because often you don't see the UTI prevention or the urgency of urination prevention and treatment until you've been using it for at least 3 to 6 months. So it's really important to let our women know when they're using these medications that persistence is key.
Great point. And I think that it plays into when you hand that prescription off, take the extra minute or two to give expectations. Tell the patient, you're not going to notice any benefit right away. This is a long game root cause treatment. This is the only time I say that root cause buzzword. I say this is the root cause of root cause treatments that we have. Okay, it can't get more root cause. So this is a long game. Be persistent. I promise you 6 months from now, you're going to thank yourself for doing the work and being consistent. Let them know that initially they may have itching or burning or this and or that. If it really bothers them, hey, there are other options, but we don't give it up. Okay, but things get better. As their vagina gets healthier, this will get better. And I also tell them that they're going to be like, well, how long do I do it? And I say, until you stop having a vagina or you stop drawing breath.
Forever. Forever.
Yes.
So I think that's the one takeaway from this conversation that everyone's seared into their mind. GSM, extremely common, very
Yes.
treatable, often missed. Let's not miss it. And once you make that link with vaginal estrogen, it's a forever connection. And as we recognize May as Women's Health Month, conversations like this are such an important reminder of how common this is, and how treatable it is, and how great it is to be proactive, and how nice it is to be on the right side of history, where we see us arise like a phoenix from the ashes of misinformation, and now see this treatment being so accessible to so many women. And hopefully that can be a sign of so many more things to come for our female patients.
Amen. Can I say that? I feel like that.
Why not?
That's an amen. Whether you believe or not, that's an amen.
Thank you again for joining us on this episode of AUA News Inside Tract. Thank you to my lovely friend and colleague, Dr. Milhouse, for all of her wisdom. I always learn so much when I do podcasts with you. Thank you again.
Thank you, Dr. Santiago-Lastra. I appreciate this conversation, and I hope that our viewers or listeners really learned a lot from this.
This has been an AUA News Inside Tract podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.